Welcome to the Peer-to-Peer Podcast. New perspectives in diabetes, new targets, new therapies, and a new approach to patient management. This activity is sponsored by the France Foundation and is supported by an educational grant from Bristol Myers Squibb and AstraZeneca. Today's discussion, titled The Value of Managing the ABCs, is presented by Dr. Lawrence Leiter and Dr. Vivian Fonseca. Let's listen in.
Hello, my name is Vivian Fonseca. I'm professor of medicine and endocrinology at Tulane University Health Sciences Center in New Orleans, Louisiana. And joining me today is Dr. Larry Leiter from Toronto. Larry, welcome.
Thank you, Vivian. I'm an endocrinologist at St. Michael's Hospital and a professor of medicine at the University of Toronto. And I very much welcome this opportunity to discuss these important issues.
Welcome. So we're going to talk today about the value of managing multiple issues in patients with type 2 diabetes. We used to call it the ABCs of diabetes, A for A1C, B for blood pressure, and C for cholesterol. But I think we need to think beyond that about the comorbidities that patients have, the complications of diabetes that they may develop as the disease progresses, and how those may interact with patients as we treat them. So, Larry, what's your strategy for managing patients with multiple disorders?
So first off, I think it's important to highlight that overall we're not doing a very good job. We've recently done a study in Canada that has virtual identical results to an NHANES survey in the United States, that overall only 15 to 20% of our patients with diabetes are reaching the guideline targets for A1C, LDL, and blood pressure, let alone the many other considerations. So I think we need to develop better strategies. I think the first strategy, of course, is to be organized and to try to approach the patient in a fashion that one will not miss anything. And I think for those of us who see primarily patients with diabetes, it's relatively easy because that's the topic of the visit. The patient knows that he or she will come in to discuss their diabetes management. At the primary care level, when patient may be coming in to discuss a twisted ankle or to get their flu shot, one has to change the agenda to make the control of these various factors important, because we know, of course, that if we truly want to minimize the risk of complications of diabetes, we do need a multifactorial, multifaceted approach. Certainly, electronic medical records will help because they'll highlight what one needs to do at each visit. In the absence of that, certainly flow sheets will help provide reminders as to when something was last done and what one needs to do. And of course, one needs to choose appropriate pharmacotherapy that will try to treat the greatest number of issues with the fewest number of medications. So Vivian, how do you approach pharmacotherapy in a way of optimizing treatment and minimizing complications?
Well, first of all, for the ABCs, we have multiple drugs targeting A1C, blood pressure, and cholesterol. I don't have time to specifically discuss each of those, but very often patients need combination therapy. What I find a lot more challenging are patients who have multiple comorbidities. Patients have heart disease or heart failure, for example, may not be able to take a glitazone, for example. On the other hand, somebody who's got obesity and has a problem with blood pressure, using a drug that might lower glucose as well as blood pressure may be helpful. So we could consider using a GLP-1 receptor agonist or an SGLT2 inhibitor. The biggest challenge comes from patients with renal impairment and hepatic impairment. Hepatic impairment is less of a problem with the diabetes medications, but the patients tend to be very sick. In contrast, with renal impairment, even at the relatively early stages of the renal insufficiency, one has to consider the impact on diabetes medications. So there comes a point in time where metformin has to be perhaps discontinued. A DPP-4 inhibitor may need a dose reduction, although there is one linagliptin that is not excreted by the kidney and doesn't need such a dose reduction. Patients starting on a GLP-1 receptor agonist may have some nausea and vomiting, which may cause dehydration. So you have to use such drugs with caution in patients with renal insufficiency. And in fact, some of them have a contraindication in their label in people with advanced renal insufficiency. With SGLT2 inhibitors with an eGFR less than 60, they recommend more frequent monitoring of both blood pressure and renal function. And they seem to lose their efficacy as the GFR falls below 45, and they are not indicated in patients with a GFR less than 30. So I think the renal patients are very challenging. You've got to make changes in the medication and stop others, and we're left with fewer options there. But I think, we have to think about safety of the multiple medications the patient may be taking. So what do you do for that, Larry?
No, I agree. Certainly, safety is always something we must consider, although fortunately, with many of our newer drugs, safety seems to be less of a concern. And in terms of drug interactions, certainly we need to choose drugs that do not interact. I mean, I think always there had been concerns with sulfonylureas and risk of hypoglycemia. And for example, in the renally impaired patient, they're more prone to hypoglycemia, and this is a population where I particularly try to avoid sulfonylureas. And certainly in the renal patient, we know that their vascular risk is very high, and we want to do whatever we can to reduce this risk with appropriate management of their lipids and blood pressure, in addition to all of the other routine risk factors. Of course, in the renal patient, on top of all of our patients with diabetes, they're on many, many medications. It's been estimated that our typical patient with diabetes will be on 7 or 8 different types of medications just related to their diabetes and its comorbidities, let alone other associated conditions. And if a patient has renal failure, renal impairment on top of that, they're on even more medications. So, Vivian, how do you cope with this problem of adherence with multiple medications?
Well, it's very challenging. There are multiple issues for the patient. One is the cost, the other is the pill burden. And patients often are taking only a subset of the medications we prescribe. You mentioned electronic medical records, and I think that may be a tool that we could link with pharmacies to see who's refilling their medication and who's not, so we can send them reminders. So there are technical advances like that that might help. Maybe some people need reminders to take their medications, refill their prescriptions, and so on, as well as giving patients repeated information that might help them adhere better to therapy. I think we need to educate our patients on the value of overall control, not just being glucose focused, control the blood pressure, control the lipids, manage their other comorbidities. And if they meet multiple goals, there is evidence to suggest that they might do better than just meeting only one goal.
Yeah, no, absolutely. And I think sometimes we fall into the trap that we assume that our patients of higher socioeconomic status have less of an issue with adherence. And of course, multiple studies have shown that that's not the case, and that physicians are really not good at all in predicting which of our patients take their medications and which do not. And what I would add to your excellent suggestions is to always ask patients about adherence. And of course, one needs to do so in a non-threatening fashion. And one trick which one of my colleagues recently suggested that I've had great luck with is I open with, it's very difficult to take multiple medications, which one do you have the most difficulty with? And by asking it in such a fashion, I'm always quite amazed at the answer that one would get in terms of some pills which the patients will admit they never take, as soon as we give them the opportunity to enter that into the conversation.
That's very interesting. I think these are all things we need to focus on as we see our patients and try to get them to all the multiple goals that we have set for the prevention of diabetes complications. Thank you very much, Larry.
Thank you.
This concludes the discussion. We would like to thank Drs. Leiter and Fonseca for their contributions and continued support. Thank you for listening. To receive credit, please complete the evaluation form found on the website www.t2diabetescme.org.